a 32-year woman is there, 32-year woman, and she is coming to the office distraught because the colors looked washed out. What do you mean by this? Colors looked washed out. So you have to actually, describe each and every line. You have to see what they're trying to say. The colors looked washed out. Then she had this vision impairment since yesterday. So whatever is taking place, that is actually sudden, because these problems are taking place only since yesterday. She is also complaining of a very, very typical thing, and that is your pain on eye movements. Colors looked washed out. So there is a problem. There is a defect in the color vision, right? We have a defect in the color vision, and there is also the pain on the eye movements. Her vitals are stable. Can you tell me, what are you thinking if I am having a pain on the eye movements? Then what is the first thing that is coming to my mind? First thing, and also you have to tell me which extraocular muscles are usually involved while you are having the pain. While you are having the pain on the eye movements, especially which muscles I am talking about. Her vitals are stable, she's afebrile, then she is having the decreased visual acuity, sluggish afferent pupillary response to light. She is having the diminution of vision also. She is having the diminution of vision and RAPD. What is the meaning of this RAPD? One is this question and another is this question. Suraj is saying inflammation. No. I am saying when I am having a pain on the ocular movements, which muscles, inflammation of which muscles are you thinking about? What are you thinking about? Pain on ocular movements. What is the condition? What is the condition that you are thinking about? Now this condition leads to the tenderness. It leads to the tenderness in the extraocular muscles. So which muscles? And also I am asking you that which condition are you suspecting if you are having RAPD? What is the meaning of RAPD? These are the three questions. Suppose we are discussing this case. So I am actually interrogating you. You are giving me the case history and I am interrogating you. Okay, we have got pain on eye movements. So what are you thinking if you are having pain on eye movements, you are having sudden diminution of vision, and there is also a defect in the color vision. So what are you thinking if you are having pain on the eye movements? So first is this question. This is your question number 1. Now once you tell me the answer of this question number 1, then we will go to question number 2. Which extraocular muscles will be tender? And then I am asking you the question number C, RAPD. Anik is saying, no, I am not asking the full form of RAPD, beta. That is okay. It is. I think that is also given. That is also given in the question. I am asking what is the meaning? What is the meaning of this? Meaning. You are giving the right example. CRAO, CRVO, optic neuritis. Meaning क्या है इसका? What are you having? That means we have some optic nerve defect. That was the question that I wanted to ask. So that means we have some optic nerve defect. You are giving me right examples, CRAO, CRVO. And we are also thinking about the optic neuritis. Okay? I am also thinking about the optic neuritis. Now, which of the following is giving you sudden diminution of vision? All of them gives you the sudden diminution of vision. All of you are giving me the sudden diminution of vision. But pain on ocular movements, which of these conditions will give me pain on ocular movements? How will you say that whether it is CRAO, CRVO or whether it is optic neuritis? Like we can have CRAO, CRVO, optic neuritis. Okay? Now, which of the condition will give me the defect in the color vision also, pain on ocular movements? Is this any of these conditions, or it could be something else also? We are having the RAPD even in cases of retinal detachment also, we can get this. Now, all these conditions will give me sudden diminution of vision, but which of the following condition will give me the defect in the color vision also? Along with this, they will also give an pain on ocular movements, eye movements, and then they are giving RAPT. Which of the following conditions? Who will answer this? Suraj? CRAO is painless. Painless, so even CRAO, CRVO, these are also painless. Okay? And retinal detachment is also painless condition. It is also a painless condition. So what is optic neuritis has color vision? Exactly. So it is actually this optic neuritis which is giving me the defect in the color vision. In the color vision. And also the painful ocular movements. No, Parth. Optic neuritis does not mean the gradual. Optic neuritis will also give me sudden diminution of vision. Who told you optic neuritis will give you gradual? It is optic atrophy. Optic atrophy gives you gradual. Optic neuritis will give you sudden only. See, these are the things you will come to know. Nimai is saying C. Nimai, how it is C? Acute anterior uveitis will give you defect in color vision or eye painful ocular movements. Both of the things will not be present in acute anterior uveitis. Now, see, if I talk about the acute anterior uveitis and acute congestive glaucoma. Acute anterior uveitis and acute congestive glaucoma, both of them will cause sudden painful diminution of vision. Both of them will cause sudden painful, but there will be no RAPD. So you have to see something which should have RAPD also. Normal color vision. There will be normal color vision. Plus acute congestive glaucoma will be found in more than 50 years of age. You should also have colored halos. So we are not thinking about this. There will be no pain on the ocular movements. There will be no pain on the ocular movements. So we are not thinking about acute anterior uveitis or acute congestive glaucoma. We have been given a female that is 32 years old here. What about open angle glaucoma? If I have a patient of the open angle glaucoma, then this patient will be more than 60 years of age. More than 60, and we will have gradual painless progressive diminution of vision. So again, this is not the case. So that means you have ruled out the uveitis and glaucoma. What will be the presentation of orbital cellulitis? What will be the presentation of orbital cellulitis? Are you getting this? How we will rule out the things? Then what will be the presentation that you will get in the orbital cellulitis? Orbital cellulitis. So who will tell me what will be the presentation? Do you remember it is the most common cause of unilateral proptosis in children? Most common cause of unilateral proptosis in children. So it should be a child and we should have a proptosis. Then there will be no RAPD. There will be no pain on ocular movement. There will be no RAPD, no pain on the ocular movements. There will be normal color vision also. Normal color vision. So these are the things that you are going to get in a case of orbital cellulitis. Orbital cellulitis. So what is the answer? So that means now you are remaining with the one option, and that will be your optic neuritis. Optic neuritis may we will have a problem with the color vision, sudden diminution of vision, pain on ocular movements. We will have decreased visual acuity, RAPD present, and changes in the color perception. Then they are saying fundoscopy reveals a swollen disc. Now the two questions: what kind of optic neuritis it is? Number one. Number two, what are the muscles which are basically involved? There are certain questions that we have to see if it is a case of a optic neuritis. These are the questions that will be asked from you. Optic neuritis है, ठीक है? So what are the muscles which are specifically involved in the cases of the optic neuritis? Which extraocular muscles are actually involved? Which extraocular muscles are actually involved? Very good. Oh, Avinash is also there. History of sinusitis, yes. Cavernous sinus thrombosis is equal to bilateral proptosis. Cavernous sinus thrombosis is actually unilateral to start with, and in 50% of the cases it will go to the bilateral one, plus it's an emergency condition. More common in children. You will get a history of orbital cellulitis. You may get a history of acute ethmoidal sinusitis. You may get a history of infection in the dangerous area of the face. You will have pain, ophthalmoplegia, chemosis, congestion, optic disc congestion bhi hoga, but there is no problem of color vision. There will be no pain on ocular movements, no RAPD, all these things. So which extraocular muscles are involved? The extraocular muscles which are involved are the superior rectus and the medial rectus. Specifically, it is the superior rectus and the medial rectus because these two muscles are adherent to the optic nerve sheath. These two muscles are actually involved and they are adherent to the optic nerve sheath. That is why basically these two muscles are involved. Another question: which type of optic neuritis? Which kind of optic neuritis is this? Who will tell this? Like, we have got three kind of optic neuritis. You all know we have papillitis. Then we have neuroretinitis. And then we have the retrobulbar neuritis. So what do you think? According to the question, which kind of optic neuritis is this? Anybody who can answer this question? One question is this. Another question is, what is the best test for the optic nerve? If I want to assess the optic nerve function, then what will be the best test? Any other person? See, they are saying that if you look at the question, let's look at the question again. If you look at the question, they are saying one line. They are saying that we have a swollen optic disc. We have a swollen optic disc. That means I am having the optic disc changes. So if I am having the optic disc changes, then one thing is very, very clear, that it is not a case of retrobulbar neuritis. In the neuroretinitis, you will typically have the macular star formation. And in the papillitis, we will have the swollen optic disc. Plus redness will be there. So therefore, it is a case of papillitis. Very correct. Though it's more common in children, but this is a case of papillitis. Very good. So each one of you is correct. This is papillitis. Another question is, what is the best test for the assessment of the optic nerve function? What do you think is the best test if you want to assess the function of optic nerve? Now, one thing is very, very sure, that this is a case of optic neuritis. So I will have to see the function of optic neuritis, because we are also having the RAPT. You will have to assess what is the earliest indicator of the optic nerve disease function. And what are the tests that you would like to do? Like, what are the tests that we can do, and amongst that, what is the best test? Anybody who can tell me what are the tests that we can do? Like, first, I am looking at the fundus. So in the fundus, I will get different things in cases of papillitis, in cases of neuroretinitis, and retrobulbar neuritis. Then you are going to get what you called as the central या फिर centrocecal scotomas. Central या फिर centrocecal scotomas we are going to get. So where you are going to get this central or centrocecal scotomas? Fundus में you already know we have the optic disc edema. We will get this. ठीक है ना? Then what else? One important sign was RAPD also that you have seen. Then what about the visual evoked potential? What about visual evoked potential? And what is a visual evoked potential? Where do you get these scotomas? And what is a visual evoked potential? Zach, you will have to check your notes if it is not there, because we are teaching everything in FMG too, because right now there is not a much difference between the FMGs and the PGs. So these are the basic things that even FMG students should also know. And I think you must be knowing this, that maybe afterwards, after a year or so, you people will be having the same paper as the PG aspirants. There will be common paper. CSR and CME, IGCR. Godappa. Godappa, we are talking about optic nerve, beta. How you are telling about angiography. We are not going to do the angiography here. Yes, we can do the visual evoked potential, but the best one, I am asking you the best. So the best is actually the perimetry. It is the perimetry, and on the perimetry, or specifically speaking, because this is showing you the central area, so specifically it is the campimetry, perimetry or the campimetry. It is where you are going to see the scotoma, central scotoma, or we can have centrocecal scotoma. Cecal का मतलब क्या है? Cecal means involving the blind spot. Cecal means it is involving the blind spot. Now, visual evoked potential is also a good one. See what happens. We have got three tests. One is EOG, one is ERG, and one is VEP. ठीक है? What is EOG? It is the electrooculography. Then this is electroretinography, and then we have VEP. This is your visual evoked potential. So electrooculography measures the resting potential. This actually measures the resting potential of the eye, which is there between the cornea and the macula. This area is the cornea and this area is the macula. Cornea is the positively charged, macula is a negatively charged. This is actually electrooculography. Now, electroretinography will measure the changes in the potential. Changes in the potential due to the flash of light. Changes in the potential due to the flash of light. The changes there which are occurring, this will be measured by electroretinography, and these changes are recorded by this. Changes are recorded by the VEP. So what you are going to get is the decreased amplitude and prolonged latency. what you are going to get in cases of optic neuritis, the changes, you are going to get the decreased amplitude and the prolonged latency. Why? Because if you see the most common cause of the optic neuritis. Now another question for you guys, what is the most common cause of the optic neuritis? What is the most common cause of the optic neuritis? Why we are getting decreased amplitude and the prolonged latency? Perimetry will tell about only the optic nerve head. No, Avinash. Perimetry will not only tell the optic nerve head. Perimetry actually will tell you about the visual field charting. Whole of the visual field, and visual field will tell you about whole of the optic nerve fibers, not only the optic nerve head. It's going to tell you about whole of the fibers. That is why the best is perimetry. Perimetry is considered to be the best investigation for the optic nerve, right? Yes. VEP for best test. No, VEP is not the best test. I hope I'm clear to you. What is the most common cause of optic neuritis, by the way? What is the most common cause of optic neuritis? Can you tell me the causes of optic neuritis? Etiology. Like we are discussing the case of optic neuritis here. So let's see. If I'm talking about the causes, one is your multiple sclerosis. Multiple sclerosis is there. And this multiple sclerosis is a demyelinating disorder. Demyelinating disease. So this demyelinating disease is actually the most common cause for the optic neuritis. ठीक है? उसके अलावा we can have the inflammatory diseases. Inflammatory diseases, like we can have the posterior uveitis can be there. Then number 3, we can have the ischemic diseases like anterior ischemic optic neuropathy. Number 4, we can have the toxic optic neuropathy. Toxic optic neuropathy. Toxic one can be occurring. This toxic one is due to a multiple drug induced. Like we can have the methyl alcohol. Then we can have ethyl alcohol. Methyl alcohol, ethyl alcohol. We can have tobacco, digoxin. Then we can have ethambutol. Then we can have the isoniazid. All these are the different causes of toxic optic neuropathy. We can also have the hereditary causes. Hereditary causes may we have Leber's hereditary optic neuropathy, which is having the mitochondrial inheritance. Mitochondrial inheritance pattern. Where do you get the altitudinal optic hemianopias? Another important question. These are all the causes of the optic neuritis. These are all the causes. Avinash, trauma is not the most common cause. Trauma is not the most common cause of optic neuritis. It is actually the multiple sclerosis, demyelinating disease. That is the most common cause of the optic neuritis. उसके अलावा morning glory syndrome. Morning glory syndrome is not a case of optic neuritis. That is a scleral defect where you have absence of the lamina cribrosa. Yes, hereditary है, toxic है, nutritionals है, ethambutol है, isoniazid है, methyl alcohol, ethyl alcohol, tobacco, digoxin. All these are there. Where do you get the altitudinal hemianopias? It is anterior ischemic. We get the altitudinal hemianopias. This is your altitudinal hemianopias that you are going to get in cases of anterior ischemic optic neuropathy, altitudinal hemianopias. Yes. So what should be the treatment to complete the case? What should be the treatment that I should give to this patient? Treatment may we have to start with the IV methylprednisolone. Start with the IV methylprednisolone and you have to give it for 3 days. So give this IV methylprednisolone for 3 days. Then start the oral methylprednisolone. Oral one you can give for 11 days. First give IV for 3 days, then oral for 11 days, and then taper in the next 3 days. You have to taper it. So total 17 days treatment I have to give. This is the treatment of optic neuritis. The treatment of the optic neuritis. So are you clear with this? And Avinash, I think you were the one who had asked me how to differentiate the optic neuritis from papal edema. So were you clear on that? In the papal edema, you were getting the enlargement of the blind spot there.